Okay, doctor, we are live. We can begin.
Good evening, everybody. It's quite a rainy, windy evening here in Mumbai, Wednesday, and I welcome you all for this today's talk on in Abbott Expert webinar. We'll be talking about bailout complications and bailout PC. I will be discussing all of that. And today we have two very eminent faculties on the jury here to judge the cases. We have Dr. Ronnie Matthew from Lissi Hospital, Kochi, and he's been since the time of inception of the hospital. He's been there since 1999, and he's been doing great work there. And in fact, it's one of the centers of excellence in imaging. And a lot of interest in OCT. He himself takes a lot of interest in complex PCIs, bifurcations, and he's also one of the proctors for OCT. Welcome, Dr. Ronnie Matthew, and we're good to have you here with us. The second panelist we have here is very Dr. Ajit Menon, and he is a very senior interventional cardiologist attached to Leelavati, HN, and Breach Candy. He's also a proctor for all complex interventions, left main interventions, and in patients requiring FFR, rotablation. He's also a proctor in such scenarios. And welcome, Dr. Menon, and I'm sure both of you will add great distinct to the present discussion that we will have on bailout, and especially judge the cases of one-on-one as to what could have been done better, or maybe your viewpoints on how we could have improvised the situation better. Welcome, both of you, and I let Dr. Ronnie and Dr. Menon to take it forward from here.
Rolling, go ahead. We can get the proceedings rolling.
Right. I know. After your welcome, we can start.
I welcome everyone onto this, and I think this is going to be a pretty interesting session on how to bail out problems that you face suddenly, and that is something which I think is a test of your patience, a test of your sensibility, and a test of your guts as to how to bail yourself out of situations you have probably landed up inadvertently in. I think it's going to be a great teaching experience for all of us, including us, because there will be certain situations which probably we have never faced, and it's something which we are looking forward to learn. So, Ronnie, anything that you need to add?
No, I think absolutely. Let's start off with Dr. Srinivasa, and I think he's going to talk to us about false lumen stenting, stent exclusion. Dr. Srinivasa Prasad, I think he also does not need any introduction per se. He's a senior consultant interventional cardiologist at the Fortis Hospital in Bangalore. A very good speaker, especially when he animates and tells us about how he puts a stent, and I'm sure you're going to enjoy his lecture. So over to you, Dr. Srinivasa Prasad.
Thank you, sir. So I'll just share my screen. So my slides are visible, sir?
Yeah.
So is my slide visible? Yeah.
Yes.
Okay.
Yes.
So good evening, all. Thanks to our team for accommodating me over here. So this is a case of actually a false lumen stenting, which we bailed out by excluding that false luminal stenting away from the lumen. So it's a false lumen stenting to stent exclusion away from the lumen. This is what. So this case actually belongs to my friend, Dr. Mitesh, who practices in Philomena Hospital at Bangalore. I was called only for the bailout, so I was a part of the bailout. And my thanks to Dr. Mitesh for allowing me to present this case over here. This case, actually, we did it in March 2019. This patient is a 51-year-old female who presented with the inferior wall STEMI with a window period of 1 hour, who had a pulseless VT on admission, which required a DC cardioversion. EF was 45%. There was no mechanical complications. So she was an ECLIP 1. There was no other atherosclerotic risk factors. So ECG shows an ST elevation in inferior lead. Echo shows EF of 45%. With an RWMA. So this is an angiogram which shows right coronary artery is normal. This is a left coronary artery picture. So you can see over here that L6 is kind of pinched off here. If I play this, so you can see that there's a kind of a bridging phenomena over here, which is a bit unusual for this area. But otherwise, STEMI 3 flow some kind of ulcerated plaque over here. So LAD was absolutely normal. So the diagnosis at that point was recanalized LCX lesion. So the same thing was conveyed to the attenders, and they were told that the patient will be moved to the coronary care unit for the further management and no need for any intervention. When they were getting ready to shift her out, she again had one more VT which needed a DC cardioversion. So immediately one more check angio was repeated and L6 was almost closing. So initially thought it could be a spasm, but there was no response to the nitrate. So decided to go ahead at the PCI to L6. This was the shot just before the angioplasty. You can see that the L6 has now started closing off. So which was wired with a choice floppy wire, which was a workhorse wire of my friend over there. So it went nice, and I believe that it is in a true lumen at this point of the time. So, but however, with a wire in situ, patient was quite restless with a worsening angina. So called for a direct stenting. So, however, when the stent was taken, this was a 2.75 into 32 Des. So it was found to be short in length. So nevertheless, it was deployed at the distal most part of the lesion over here. So just after the lesion, the patient's pain was worsening and distal flow was not there. There was no response to nitrate or nicorandil. At this point, the DDs would be kind of a spasm versus edge dissection. So he was trying with the nitrates and nicorandil. However, there was no response. Meanwhile, patient had one more VT and wire came out partially, which revealed there was a distal edge dissection at the stent. So reverse was again a challenging. It was not going into a true lumen at this point, and the acute vessel closure began. So patient was writhing with angina. BP started crashing. Started on inotropes. Initially 1, 2, and probably the third inotrope was also started. Called for the help. This is the time I got a call. So we told like, okay, let's take a buddy wire and leave that wire in situ and try to cross it over, probably with a knuckle. And if needed, we can use a microcatheter. You can see that there's a lot of tortuosity over here. Probably without a proper support, you will not be able to maneuver your wire properly. So anesthetist was called, patient was being sedated. So parallel wire or a buddy wire technique tried, did not help. So knuckle wire kind of probably sorted out the problem here. So with the help of a microcatheter, so wire could be crossed over. So distal edge, some balloon dilatation is done, and there's a balloon dilatation which was done. At this point, we got a TIMI3 flow back again. So, but on looking at the angio, there's a distal edge dissection and also a proximal dissection. You can see that it's over here. So BP lower on down, but still he gave a lot of nitrates, nicorandil, TIMI3 flow was there. So at this point, he thought everything is under control. He just needs to stent a distal edge as well as a proximal edge. So, but as it goes on, so suddenly patient moved violently because of angina and wire came out. Recrossing again became a challenging. So it was not going through the distal edge. Probably it was going frequently into a false lumen at this point of the time. So, and patient became more restless. One more VT, deciverted, vessel started closing down. Anesthetist increased the sedation. He said he has to give a general anesthesia. Now probably may have to be intubated as well. At this point, he saw the vessel was closing off very acutely. He decided for stenting the proximal edge initially. So at least the flow can be restored partially. So this is what he did. He took a stent proximally. He deployed it. Just as he was deploying, he saw this. The stent was side by side, not telescoping one into the other. So you can see he just took a cranial angle, even the same thing was there. So he was kind of frustrated. Yeah, you can see that the proximal stent is here, distal stent is here, and the wire is probably, when he had rewired, has gone through the side of the stent and has entered over here. Probably all this part of it is probably in a false lumen. So frustration keeping on, mounting on. So he went out and updated the relatives that the patient is really bad. He might lose. The patient attenders were not ready to take that story. Meanwhile, inotropes were increased. Femoral access was taken for IABP. Anesthetist was getting ready for intubation. He also had a tough day. He was not able to intubate her properly at the first go. By the time I just arrived at the cath lab, outside the mob was creating some issues over there. But anyhow, I entered it. So I saw this side-by-side stent wire had come out by that time again. So definitely a tough situation to be in. So patient was really crashing down. BP, despite 3 inotropes, was not going above 70. and there was no surgical backup at the site. And with this crashing patient, there's no point in shifting her to any surgical center. And relatives were updated that definitely it's a critical condition. We are trying our best. So while analyzing, I just went through quickly with the entire angiogram sequences. I felt this is a type 2A SCAD. There was no imaging modality available to confirm the same. So, however, I said in the absence of imaging modality, one of the major pointers towards the true luminal area is the origin of the side branches. If there's a side branch over there, then at least that area is in a true lumen. We don't know what has happened in between. So there was probably two stents. The distal one was placed probably in a true lumen because the wire was very good. And the second one is placed over here. Probably the distal edge of the proximal stent is probably in the false lumen. So now what do we do? There's only one way. You have to connect true lumen to true lumen so the flow can be restored. So we had three wiring options. One is wiring from this edge of the proximal stent and this, but given the closed cell design at the stent edges, because nowadays all the stents are hybrid cell design, the balloon tracking and other things would be an issue. So second option is go through the proximal stent and enter the distal stent somewhere in between. But we know that this could be high chances that this is in a false lumen, and any balloon dilatation over here means we can rupture the vessel. So that is again not a preferred option. The third option is we decided that we can enter through the middle of this proximal stent. Since we know this stent is probably in a true lumen, we can track through. So this is what we decided. So initially I took a BMW, give a large J-tip so that the entering into the stent will be very, very nice and it will not go beyond the stent stretch. So this is what I'm trying to do here with a J-tip crossing over the proximal stent. At the distal stent, it looked like it is entering into the distal stent here. However, when I took a cranial view, I noticed that this part of the wire is in a false lumen. This is outside the stent here. So here I thought anyhow, there's no point in trying this method. So I took a microcatheter. You can see the microcatheter coming over there. I kept it close into the proximal stent over here, and then extended it to a CTO wire. Initially, we tried Gaia 2 wire. Gaia 2 wire was not able to go through easily, so I extended to Miracle 6. So this is Miracle 6 wire here. I have just come out of this proximal stent and it is looking toward the stent here. Then in this picture, you can see that just trying to track it parallel to the stent. And as I approach the distal stent, I'm trying to turn it away from that stent and facing other side and making a small J over there so that I can enter the distal stent with a J tip so that again it does not go by the side of the stent. You can see that the J is entering into the distal stent. So J is entering into the distal stent over here. So at this point, so I wanted a confirmation. Only way is orthogonal view. I went to the orthogonal view. You can see that the J is definitely inside the stent. So once I made sure it is in the stent, the other way to confirm it is in a stent and in a true lumen is I have to enter a branch. This is what I'm trying to do here. I'm going down with the J. Now I know that there's a branch here. I've entered a branch. Once I took another view, so this confirms that I am in a branch. So at this point, I know that I'm in a true lumen now. Then took it away from the branch again. So then again made a small J curve over there, deflecting it. So then going across the stent truly. And then with a small J and probably here some luck helped me. With a small J and a knuckling, I was able to cross through the distal edge dissection easily. So we know Miracle is an hydrophilic wire. Sometimes it can cause a false lumen extension also. But our injection showed us that I'm in a true lumen. You can see all the branches over there as well. So having done this, now I had another problem. The microcatheter was not crossing over at this point of the time. So I thought rather than exchanging this wire for a regular wire, let it be over there and let's finish the procedure because the patient was not really doing well. Though she was sedated now and they were trying with an ambu bag and other things. So and NIV, I wanted to finish out the procedure quickly. So I took so ballooning over here. So creating some space over there, you can see that the balloon is here and you can see the crushed part of the stent over here. So both are in parallel now. Now track this balloon down. You can see that the balloon is going down. Being a CTO wire, you may not be able to appreciate well. That's why I put an arrow. Then pulled it back. So it was easy go through. So I know that anything else will track now. So then took an 2.524 distally stented. So TIMI3 flow achieved over there. Then using the same stent balloon, I crushed the remaining part of the proximal stent over there. So you can see that the stent is being crushed over there. So this image, you can see that the stent which is crushed over here and the wire is here parallelly. Then proximally, I stented a 3 into 48 Zion stent over there, which is seen here, and post dilated. So after that, this is the final result. So I got a good patent lumen over there. Okay, you can see the crushed up stent as well over there, working, seeing something like a cap over here. This is a stent which I called as excluded the stent away from the lumen. So this is another view which showed good TIMI3 flow with a good luminal patency. So in summary, what we had was a smooth narrowing of this OM branch. So I think it is a type 2A SCAD. So in this diagnostic conjure, this squeezing or bridging in an unusual position could be a clue for the SCAD, but probably an imminent closure. That's what had happened just before the intervention. So intramural hematoma is the pathophysiology between the type, defining the type 2 SCAD. This is how it would look. It would look like a smooth narrowing over here, which was there. In our case, it was 2A, that is saying that distal tip of the vessel is paired. So this was intramural hematoma. It would be something like this. So probably when he wired initially, it was in a true lumen. The distal stent, which was placed distally, so which was placed over here, but it created a distal edge dissection as well as a proximal dissection extending into the hematoma portion. And then when the wire had come out while dealing with the VT, the second time when you crossed the wire, probably it went into this false lumen and then into the stent struts. So this, without being noticed, was stented with a proximal stent, part of which was in a false lumen here. And what we did was, when I came here, this was a scenario. So I took a CTO wire and crossed it by going in between the middle part of the stent, then entering the distal stent in a true lumen, and then with the some knuckle crossing over to the distal vessel. Then stented distal part of the distal edge stent. So this edge dissection was tackled. Then using the same stent balloon, I crushed the proximal part of the stent, so which got crushed off like this. Then used a longer stent, then probably stented this. So this resulted in a good luminal patency with a TIMI3 flow. So BP got stabilized over the next 2 to 3 hours. Inotropes were tapered and stopped by 8 hours. She was looking quite pale on the table at the end of the procedure. So ABG hemoglobin showed 8 grams, so we transfused 2 units. She did have a renal dysfunction, pre-renal, which was managed conservatively. Moved to ward on day 3, discharged on day 5. On day 5, she was pain-free, was mobilizing actively. ECG had shown ST resolution. EF had marginally improved. Creatinine had normalized. We plan to do a check angio with intracoronary imaging and follow-up. 3rd month, she was asymptomatic, was not on any anti-anginals, was on DAPT and high-dose statins. TMT was negative, but was not willing for a check angio because there was a marriage at home. So 15th month, that is June, when we followed her up, she was asymptomatic, but given a corona condition, she didn't want to undergo an angiogram and follow up now. She would be coming for the follow-up in probably somewhere around September, October. At that time, we plan to do an imaging also. So type 2 SCAD can be deceptive. SCAD PCAs are often associated with procedural complications. Acute vessel closure due to false lumen stenting is often catastrophic. Sometimes on-table death is imminent, or it can cause a huge impact, leading to severe LV dysfunction. Imaging would be better in guiding the procedure. If it is not there, probably using an anatomical knowledge that branch point can only arise from 2 lumen points, you can tackle at times. So with this, let me stop over here. If there's any questions or discussions, I'll take it.
Thank you, Mr. Srinivasa. And I think truly that's been an incredible case. And you have, with your animation as usual, described it very well. And I think a lot of points, but what I take at the end of it is, despite a restless patient and a bad day for everybody from the anesthetist to the cardiologist, what makes a difference, the presence of mind and a thought process. And I think you did incredibly well.
Thank you, sir.
I think the learning point that you said, the first point, and I think that is something that we must understand. Whenever in an acute MI you see a smooth lumen, in an acute MI setting with an ST elevation, we must always think of a scan being the most common reason, and you must not come out of the lab unless you image or unless you're very sure that you're not dealing with an scan.
Yes, sir.
I fully agree, Ronnie. I mean, when you see a lesion like that in the circumflex, it's not an area where I mean, it is in the AV groove. It cannot go anywhere else. So when you see something which is collapsing and opening up, and a smooth narrowing, it's very commonly a spontaneous dissection. And very often, sometimes we do see that the angiographic dye itself is thrombogenic to a certain extent. So we have seen situations where we do an angiogram and you come out of the lab, in 15 minutes the artery starts closing off. So it's probably something to do with the, I mean, there was a dissection and we precipitated a sudden closure with the dye. But I think, like you said, two things. One is imaging would have been of a great help. I'm sure Ronnie will have a lot of things on that, because spontaneous coronary dissection is something which is very well picked up on imaging. I just want to ask you two questions. One is, why was the hemoglobin so low at 8?
We don't know.
Have any
Probably
reason to think
she had an anemia previously. I didn't know. You know, she did not have any other atherosclerotic risk factors. So, on reviewing the entire scenario, I was thinking SCAD as a reason. But the cause for anemia was later on worked up. That is after 3 months. So, she had her baseline hemoglobin of around 10.5. I think during the procedure, 1.5 to 2 grams would have been lost because it was pretty long procedure for around 2.5 3 hours. By the time I reached, already it was 1.5 hour into the procedure, and I took other 40 minutes to bail her out. So I think some blood loss also.
If I may just add 2-3 points which I thought were extremely important in this. One is the sizing of the stent distally. You probably oversized the stent distally, and that's why you ended up with a dissection distal to the stent. Yeah. Number two, so whatever happens, whatever happens in this thing, one person should make sure the wire position is not lost. Once you lose a wire position, then you start getting into trouble. Try and maintain the wire position. And you also mentioned about side branches as an access for as knowing where the true lumen is. That's extremely important, because if you can get into two orthogonal branches, then you know that you are very well in the true lumen, because you may still get from a false lumen into one of the branches if the false lumen is on that side. And most importantly, multiple views before we deploy a stent.
True. Perfectly.
So you'll know, actually, because one angle, one view doesn't give you. I mean, it gives you a two-dimensional image. But you have to recreate that in your mind, whether it is when the three-dimensional image.
Very well said.
You pick up something.
Actually, the operator, like when the patient was restless, he wanted to finish it off quickly. That's why he called for a direct stenting. Unfortunately, the technician gave him some 32 centimeter long stent. He thought that would be sufficient. Only while deploying, he realized it. So he probably took an adequate size stent because it was 2.75 stent. For a distal edge, it was too large. So that's why probably he messed it up. Probably it would have been deployed at an eye as well. So if it happens to all of us. Longest, probably even we would not have ended up in this scenario itself. Probably the entire length would have been seen, and the distal edge dissection probably would have dealt with one more this thing. I think the frequent VT, the wire coming out, probably made the procedure more complex for him.
Now, one of the points that you must remember is, I think you would mention it very briefly. The present stents that we have, there are two types of stents. One, the design of the connectors are such that the entire length of the stent is the same as the connectors with the ring to the crown. There are another set of stents that we have at the two ends. They do not have connectors, but they become closer. And I think these are two designs that we have. So you must remember that when you have a situation like this, from the distance, you will not be able to open up the stent. And what Dr. Srinivasa did is he crossed the first stent a little more proximal than the distal end, and that is why he was supposed to flare. He was able to flare that stent. This becomes very important when you're doing a bypass. Still LED, if you leave that a little bit into the left main, you will be able to cross the strut and open it up. You can see very well on an OCT. So when you use the stent design when you are handling it, and I think that's very important to know.
Yes, sir.
I think excellent case. I mean, there's a lot of teaching to us also. And one more point, you did a good thing when which you did was take a miracle wire. I think Ronnie will agree also that when you have situations like this where you need precision turning of the wire, stiffer wires are better than the floppier wires, or the you might suddenly think of taking a Fielder XT or a Fielder FC, but you don't have control over the tip with that. You have better control with the stiffer wires. You can turn it the way you want. Of course, it is risky, but you need to be careful about that but the control is much better with the stiffer wires.
Exactly, sir. I completely agree with that. I think with Miracle, I've done a lot of CTOs, and the kind of maneuverability I achieve with the Miracle has been always excellent. So that's why I chose Miracle in this case as well.
Great. Any of the other panelists of the other speakers have any points that you can add? You're welcome. Please go ahead.
A wonderful case.
Rahul. Yeah, Prasad.
No, I think very nicely, very nicely salvaged. The only thing is, how does he make those animations? Beautifully explained. I was more amazed. Animations.
Okay. I mean, that's a secret which probably we can discuss it offline.
Srinivasa is known for.
Yeah. Thanks, sir. Thank you for acknowledging that.
Lot of metal burden now.
Really good.
We need to follow Panjo is important.
There are some 4 metal layers over there, especially at the crush part. So that's why we have kept the patient on a long-term DAPT. We plan to continue DAPT for longer time.
But I think we should move to the next case now, because we should not run over schedule. Can I invite Dr. Ahmed Sharma? He's going to speak on an emergent left main PCI. So let's have you, Dr. Ahmed, with your case.